Focus. Ideate. Innovate. Enable.
The entire healthcare scenario has to be looked upon in a holistic manner. When I use the word holistic, it's a loaded word. It doesn't mean that you'll bring into it as is commonly construed spirituality and stuff like that. No. It has to be very scientific and very cost effective.
Our next speaker is Sundeep Kapila, co-founder of Swasth India. Sundeep and Ayatin worked in various companies for a decade, including a long stint at McKinsey, specializing in the healthcare and development sectors. Swasth India website explains itself as, we're a technology startup trying to find solutions for a few niggling questions. So what are the solutions and what are those questions?
Thank you. I think the fact that this industry has so much information mismatch between the patient and the doctor or the service provider and the consumer, that makes it very, very different and very, very difficult to manage. And that's where the current situation in India, which is largely privatized healthcare, a lot of out-of-pocket expenditure that is happening, is resulting in a very tricky situation in India, right? The two major things that have happened in India because of that. The first is the inequity in healthcare. The fact that in India, if you look at any healthcare index, you have districts which are at sub-Saharan levels in terms of be it infant mortality, be it in maternal mortality or any other index, anemia levels. Right from sub-Saharan levels, we have actually districts where it's close to developed countries, right? Tamil Nadu, Kerala, there are so many places where there is this, and that's what we see in the country. And that's happening because of the nature of the industry and how it's developed. The second thing that has happened because of that is the simple fact that in India, the largest cause of impoverishment is healthcare. WHO estimates between 32 million to 60 million people in India every year go from above poverty line to below poverty line due to a health event in the family. So we are doing so much for growth. We are talking of people getting out of poverty line. We are doing 8%, 10%. But more than 20% of our current BPL population, we are adding every year due to a health shock in the family. And the single reason is our healthcare system. So, and that's from the healthcare system that we have currently. I think in that context, I would say that's where to me the role of an NGO becomes very, very critical, right? So that's sort of the thinking process where we come from, saying how do we prevent these health shocks, these 32 million people going from above poverty line to below poverty line. We've gone through a life cycle of our own. We are a 7-year-old organization. We started with looking at micro insurance in a very big way because we thought that's how we can prevent this impoverishment. And we slowly moved down. During that process, we realized the key to actually prevent these health shocks is primary and preventive care. We realize it's not only preventive care, unfortunately, it has to be clubbed with very good, solid primary care. And that's what we do essentially currently. We operate a network of primary health centers focused largely or rather entirely right now on urban poor. So we run these primary healthcare clinics which act as, or rather these centers which act as both clinics, providing basic primary care, but also an extension to provide preventive care in the community. Our focus area is right now Bombay. And just to describe our model a little bit more, what we have done, and there are numerous innovations which have resulted. We have a very small 250 square feet facility. We'll take it right in the community, in the slums, where people can walk in, they can meet a doctor, a dentist, can get access to all drugs and diagnostics based on the prescription of the doctor. In addition, there is an outreach worker who is out in the community looking at preventive healthcare, education and awareness with the people. So and at the same time, this model, the essence of the model is that it's a social enterprise, so it's self-sustainable. The center becomes cash flow positive, or it returns its capital, whatever has been invested in a 2 years time frame. And all of these services are available to people at half the market rates. The only way we have been able to manage these two equation of managing a price point which is a half, including on medicines and diagnostics, and at the same time make it self-sustainable is through a whole set of innovations which involve technology, which involve business innovations around integrating with the back end, be it on drug supply chain, be it on pathology lab, and layering it on top with data, right, which is something which again Vishal mentioned. The fact that every patient has an electronic health record, we mine that data to say what interventions are required for that person, what's the issue in a particular community in terms of the disease pattern, and what preventive measures need to be taken there. So combination of this is allowing us to basically achieve this twin goal of sustainability, which is on the business side, and as well as ensuring that it's affordable and accessible to the people.
Now I'd like to invite on stage our keynote speaker for this evening, who needs no introduction to all of you. Sangita Reddy of Apollo Hospitals, one of India's leading hospital chain, has been instrumental in forging new paths at Apollo. Apart from the many initiatives Sangita has spearheaded at Apollo Hospitals, she has been at the forefront of the organization's endeavor in the domain of telemedicine, e-health, and mobile health. Without taking much more time, let me call on stage Sangita Reddy to give her ideas in the health sector.
I was told that, the whole concept is speaking about making a difference. So 32 years ago, when my father came back from the United States with 4 young daughters in his hand with him, he set up a cardiology practice in Chennai, and his whole idea was, how can I bring the type of care that I was practicing in the US, how can I bring it to India? And one day he lost a young man before that young man had enough time to raise money and get his visa to go to United States for surgery, because 32 years ago, there was no credible heart surgery program in India. Many of you will not even remember that time when people used to go abroad, because their mortality rates were so high. And with that, he said that when Indian doctors are curing and healing people all over the world, why can't we give them the infrastructure and the machines, the equipment, the systems, so that they can do that in India? And that was the birth of Apollo Hospitals almost 32 years ago. From then has really been a journey where today about 70,000 of us are working in hospitals, clinics, telemedicine stations, insurance, the rural healthcare program, education, to find ways to bridge the tremendous gap which exists between advanced healthcare and what people really on the ground are getting. I'm very clear that a few things are definitely going to happen. Care is going to move from the hospital to the clinic to the home, and finally to a ubiquitous 24/7 access. People are going to wonder not just what to wear today, but what device to wear. Should they wear their GoQi, or should they wear their Fitbit, or should they have a patch, or will they have an embedded chip? So the entire scenario is changing, as is drugs and diagnostics. And the amount of data that healthcare is emitting, the challenge is to take that data. And it is said that healthcare is drowning in data, but dying for information. Do we have information about the cardiac problems in our country? Do we understand why Indians are getting heart disease faster than their Caucasian counterparts? Do we know whether cancer is going to recur? And which pocket of the country is susceptible to dengue, because you're already seeing spikes of fever? And if we knew that, would we change our diagnosis and would we change lives? There is so much to be done, and yet there is more, because as we go from data to information, we need to go 2 steps further to convert that into smart interactions with our patients, but also to encapsulate this into knowledge. Today, Indian healthcare is actually delivered in most organized centers. I'm not talking about aberrations and, there are lots of negative stories going around, but in a good quality center, healthcare is delivered at 1/10 of global prices. And as we've completed 175,000 bypass surgeries from that 32 years ago when Dr. Reddy lost a young man, we're doing this at 1/10 of global prices, but we're doing it on par with global results, and that is 99.3% success. And this is unparalleled anywhere in the world. And that's why people from UK, Mark Britnell, who was spoken about in the beginning, has visited our health system, is writing about India, and his book has a, kind of not just a reference to Apollo, but actually, a comment from Dr. Reddy. But I mean, all that is fine. There's some tremendous things which are happening in the healthcare system. There's innovation. Very few people know that almost 90% of heart surgery in India is done on a beating heart. A beating heart is 5 times more difficult than a heart which has been stopped. The surgeon is allowed to neatly do the stitching and then you restart. And why do Indian surgeons do beating heart surgery? They do it because they started trying to cut the cost, and the oxygenator, when you take the heart, stop this heart and you do a bypass and go into another machine, that costs 9,000 to 10,000 rupees. And so if you can save 10,000 rupees for the patient, you will innovate and find a way to do it. And that's what's happening. We're also doing simple innovations for low cost, which can bring quality on a day-to-day basis into people's lives. And with 57 hospitals, almost 9,700 beds, and soon will be coming into your city, not Mumbai, but Navi Mumbai, there is a lot to be done. But on the parallel, we're also trying to look at what's happening in rural India. And Aragonda is this example of, the hospital that we have in rural India. The population of Aragonda is only 7,000 people. And we started a 100-bed hospital over there. It was very difficult even to get doctors to go and live there, but, we found the quarters. But when we started 15 years ago, actually when Bill Clinton visited Hyderabad, he pressed the button which connected the telemedicine of Aragonda into all our advanced hospitals. So even though we had only 9 doctors there physically, we had the capability of the specialists anywhere in the Apollo ecosystem. And today, having completed, I don't even know the count of how many telemedicine interactions, but the beauty is that 87% of those who had a teleconsult could be treated in the village itself. The other beautiful part about the Aragonda example is that, like you rightly said, healthcare is actually the second biggest reason for rural indebtedness. And people sell their wives' jewelry, they sell their land, they pawn whatever they have to get that treatment. And so we said we need to find, and the only way to do that, you can innovate to a certain extent to bring down the costs, but even if you're charging 1 lakh for bypass surgery, which is almost the minimum you need to do for a quality treatment, maybe you can bring it down to 80,000, even that will break the back of an Indian farmer or an Indian teacher or a rickshaw driver. What we need, and like you rightly observed, sir, the difference between primary and tertiary care, it's tertiary care which is driving people into indebtedness. And mismanagement in rural, and then you come in with septicemia into urban care, and your bills are almost 2 to 3 lakhs. So we innovated in Aragonda a 1 rupee a day scheme, primarily for tertiary care, and this was 15 years ago. The data and the experience from Aragonda drove us then to very confidently do the Arogya Bhadrata scheme, which was done for the police in Andhra Pradesh. The Bhadrata scheme also was run by the fund in the police in Maharashtra. This went on to the Yashashwini scheme, and finally the Arogya Shri scheme. In 24 months, 8 crore people of then combined Andhra Pradesh were covered. And by then the cost had moved up from 365 to about 450 rupees, but all major ailments were covered. This data and this experience and this inspiration is the basis for RSBY. Despite these tremendous examples, only 27% of India is covered by insurance, and there is a lot to be done in this sphere. But that is the single largest answer, and I think your chief sponsor is going to be very happy today when I'm talking on behalf of insurance. But truly, unless the population as a whole can pay a small amount to defray the cost of the few, and it's only 7 to 8% of the population who get so sick, unless the whole population defrays the cost of this small number, these people cannot afford treatment. So what we need to do is a combination of re-engineer primary care and create that safety net, focus on preventive care, and I'm going to come to that in a minute, and then find an insurance scheme to cover if, God forbid, you have a major problem. And this major problem is major treatments as well as emergency. The combination of this structure is what we need to dream, design, vision, and then structure for India. I would just like to say that over 32 years we have been committed. I believe the journey has just begun and that India does have solutions. A young India can take care of a graying world using remote healthcare. A dynamic young India can prevent or reduce the incidence of major ailments using preventive care and technology and early diagnosis. And like that, I can build hundreds of scenarios. The pharmaceutical industry has innovated so much to give us low-cost healthcare. For me, the engagement with healthcare and patients is not transactional. It's not you come in once, you have this treatment and you go out. It's the building of a relationship and a continuum of a care. It's an endeavor to prevent, to cure, and to comfort. But it's also to create capacity. And therefore, we need to think of solutions which can scale. It's not enough to treat 10 patients and 20 patients. And that was a fabulous statement you said that, let's share the systems. So we need to think of scale to create capacity, including training and learning. And so our e-learning platform, there's no time to talk about it, but I think it's quite amazing. But also to transfer this knowledge and to use that data to information, to knowledge, to intelligence, to impact healthcare. But most importantly, I think, is for public to start playing a more active role. We have to co-create this health system of our dreams. We have to demand a new healthcare system for the future. Thank you all very much.
Our final keynote speaker for this evening is Sanjay Datta, Chief Underwriting and Claims of ICICI Lombard General Insurance. With over 24 years of experience in general insurance, Mr. Datta was a part of the startup team at ICICI Lombard in 2001 and has since then grown the business into a market leadership position. At ICICI Lombard, Mr. Datta is responsible for underwriting and claims division across the organization.
Good evening to all of you. I'll take you through a little bit of the fact that there has been a lot of developments in health insurance lately, and we are at the kind of crossroads. We're trying to figure out what is the role of health insurance in India currently. Where does it go? How does it go? And that to me is very, very key to what we're going to do tomorrow as we partner CNBC in the kind of awareness kind of initiative where we look at healthcare issues which are closely linked to health insurance. It's my firm belief that the two shall go together. The whole I think she talked about the kind of 32 years in which private healthcare is really taken off in India. And we've also it's roughly about around that kind of number of years in which health insurance is also developed in India. It's kind of co-terminus, if I may use that word. Why is it so? And how is it important? It's all linked to that, the most important issue of access. And access to healthcare when you need it. As health insurance developed, it was actually around about 2000, it was roughly about 600 crores of health insurance premium. Now it's about 20,000 crores. And we are currently paying out towards health insurance, healthcare access. We are paying roughly more than 20,000 crores because what we get in terms of premium, we are paying out more as an industry. Why is that so? And is that the right way, directionally? Is that the right way to go? I don't think so. It's the right way to go because if you are looking at how health insurance is supposed to grow and it's supposed to be 40,000 crores, by about 2020, healthcare itself is going to double. From here about 200 billion to about 440 billion. That's the kind of statistics we are talking about. Is this the right way to go about health insurance is my question at this point of time. But 2-3 important steps have started taking place in the ecosystem. The first is the regulator has understood that health insurance needs to grow in a very different manner to the way it was growing earlier, just as a reimbursement mechanism. The most important aspect, which is the consumer, which is the patient, the one who takes healthcare, and started developing a lot of healthcare-related regulations, which have started working very well, if I may use this word, because of the simple fact that it did two things. It said that we need to build trust in the ecosystem. The first step is to make sure the kind of policy documents, the way we sell insurance, the way we build our forms and various other kind of mechanisms needs to evolve. In a sense, we have to have a common kind of standard. That's the first step they took. The second step they took, and which was a kind of a revolutionary step, they said that very clearly that once you give health insurance to a person, you can select a person. You cannot deny any person any health insurance if he chooses to insure. That to me was one of the biggest kind of step which the regulator took. The third step was that, and if you are not happy with the service of one particular, you can't be wedded to that insurer for life. You could just start porting to another insurer. These three steps brought in a kind of a different approach to the whole aspect of health insurance as we started looking at it. So we talked about someone falling below the poverty line, 20% falling below the poverty line because they have a healthcare emergency. To us, we call it a catastrophic risk. And that catastrophic risk can happen for each one of us in the spectrum. What is catastrophe for you may be very different catastrophe for a BPL person. But to all of us, catastrophes will occur. Now, for us, let's look at the middle class. One of the most important catastrophes which can occur, apart from getting into a debilitating disease, is the whole issue of being unable to be able to fund his let's say, for example, his long-term care or his ability to take access to care on a long-term basis. That requires serious funding. And where does it come from? That's where insurance comes in. That's what we thought. And build it into a long-term, kind of model where we start building the whole savings habit, around insurance. We believe that, we could be one of those, important watchdogs in this entire ecosystem who's able to, be on the sides of all the, kind of providers in terms of the chain and be able to bring value by being there at each stage of the life of a person where after he's born, he's healthy, he could be at risk, tomorrow he could be sick, and lastly he could be someone who requires a lot of care towards the end stage of his life. And at every stage we could be there to help him in that journey with the correct choices, the correct access. That, I think, is the whole role of health insurance as it's emerging now. We are at that kind of crossroad. We are seeing a lot of activity across the healthcare segment. Everybody is focused on building a kind of a sustainable healthcare ecosystem with the right kind of partners who can, give access to that healthcare. Thank you very much. Thank you for patiently listening to me.
Focus, ideate, innovate, enable.